Okay. All right, so it is my pleasure to introduce our next speaker, Dr. Aaron Tobian. Dr. Tobian received an MD and Ph.D. from Case Western Reserve University, and then he completed a residency in clinical pathology and a fellowship in transfusion medicine at Johns Hopkins Hospital. He's currently an associate professor of pathology at Johns Hopkins University School of Medicine, and he also serves as associate professor in the Department of Epidemiology and the Department of Medicine, Division of Infectious Diseases at Johns Hopkins. Much of his research is focused on allergic transfusion reactions and the epidemiologic risk factors of HIV and other sexually transmitted infections. His presentation today will be on platelet transfusion and the prevention of adverse events. So please join me in welcoming Dr. Aaron Tobian.
Thank you very much for the invitation to speak today. It's a pleasure to be here, to leave Baltimore for a little while, and to join you in New Jersey. We'll be going back a little ways to the first speaker, Dr. Liebig's talk, and focusing a little more on evidence-based transfusion practices for platelet transfusions. One disclosure is that the platelet AV solution study at the end on the cost effectiveness was supported by an unrestricted gift from Finwald to Johns Hopkins University. So there are multiple objectives that I hope to cover in the next hour. To begin with is to review the AABB's platelet transfusion guidelines that are based off evidence. The second is to understand the risks associated with platelet transfusion and platelet consumptive and destructive disorders. Then evaluate methods such as pre-medication or plasma reduction techniques to prevent allergic transfusion reactions. Recognize that platelet additive solution apheresis platelets reduce allergic transfusion reactions, and if we have a little time, to finish with understanding the cost effectiveness of platelet additive solution platelets to reduce allergic transfusion reactions. So why do we care about platelet transfusions? Well, there are approximately 2.2 million platelet doses that are transfused annually every year in the United States. As I'm sure all of you are extremely well aware, maintaining these hospital platelet inventories is logistically difficult. The shelf life is only 5 days, so due to concerns about bacterial contamination. Thus, they're a limited resource, they're expensive, and HLA matching only compounds our difficulties with dealing with platelets. However, there are a number of risks associated with platelet transfusions, and these are data focused on the United States. A febrile reaction now is about 1 in every 14 platelet transfusions. Allergic transfusion reactions are about 2%, and then there's concern about bacterial sepsis. Trolley, hepatitis B, hepatitis C, and HIV are relatively low now with platelet transfusions, but it's important to try to optimize the clinical uses as well as to preserve the resource. If there's no real benefit for the platelet transfusion, all we're providing the patient is some risk. And it's with this setting that the AABB formed a clinical practice guideline task force and to review the randomized trials and observational studies. And so the AABB performed a systematic review to develop platelet transfusion guidelines. The panel reviewed the data and developed recommendations using the grade or the grading of recommendations assessment development and evaluation framework, which is a framework that's been endorsed by the Institute of Medicine. And there were 21 members on the panel, including pathologists, hematologists, a neurosurgeon, a cardiac surgeon, critical care specialists, anesthesiologists, and an expert in the grade methodology. That's it. We are not trying to preach to our own audience. We're trying to make sure that these recommendations will be incorporated into the community. So what are the primary recommendations? Well, recommendation number one is based on those with therapy-induced hypoproliferative thrombocytopenia, or essentially our stable hematology oncology patients. Recommendation number 1 is AABB recommends that patients should be transfused prophylactically to reduce the risk for spontaneous bleeding in adult patients with therapy-induced hypoproliferative thrombocytopenia. That was our easiest statement to make. I think everyone in this room would very easily say, I agree with that. Then we started to think more about thresholds throughout the rest of our conversation and document. And number 2 is AABB recommends transfusing hospitalized adult patients with a platelet count of 10,000 cells per microliter or less to reduce the risk of spontaneous bleeding. And these were fairly well documented. There were 4 randomized trials that supported this threshold of 10,000 cells per microliter. Looking at data from the Plato trial and 3 other randomized trials, the task force came up with the recommendation that AABB recommends transfusing up to a single apheresis unit or equivalent. Greater doses are not more effective, and lower doses are equal to 1/2 of a standard apheresis unit are equally effective. Thus, we do not need to be giving large doses of platelets. Whether we give a smaller dose or a larger dose, you have equal efficacy. The key about these grade recommendations is if you look at the end of, and this document has recently been published on Annals of Internal Medicine. At the end of each recommendation, as part of the grade methodology, you have to describe exactly what type of recommendation it is and based off what type of quality of evidence. So for the recommendation, it's a strong recommendation with moderate quality evidence. So this is very clearly a very solid recommendation from the AABB Platelet Transfusion Guideline Task Force. Now let's look at some of the other recommendations. In terms of those for minor invasive procedures, those looking at central venous catheter placement, the recommendation was that there's a platelet threshold transfusion at 20,000 cells per microliter. There were 8 observational studies that showed among individuals receiving central venous catheter placement with a platelet count less than 20,000, there was no significant bleeding. However, let's look at the quality of evidence. It's a low quality of evidence, and the strength of the recommendation is weak. And that's primarily based off there were only 8 observational studies. There's no gold standard randomized trial data. Now, if we look on to the lumbar puncture data, we come up with a platelet transfusion threshold of 50,000 cells per microliter. And the primary reason that the task force chose the 50,000 cells per microliter is that there's substantial risk of morbidity and mortality that's much worse than a central venous catheter line placement. So 50,000 was essentially what we thought there would be almost zero risk of these devastating consequences. However, the evidence goes now from low to even very low, and the strength of the recommendation is weak. Thus, there's still significant room for improvement in learning about these platelet transfusion thresholds. What about major invasive procedures? Well, there were numerous studies looking at among those individuals undergoing general surgery, among those individuals who had a platelet count threshold of greater than 50,000, even without receiving prophylactic platelet counts, there is no coagulopathy during the surgery. So the AABB's platelet transfusion guidelines recommend a platelet transfusion threshold of 50,000 or less. However, again, the evidence of quality of evidence is very low, and the strength of the recommendation is weak. In terms of those individuals on antiplatelet therapy with intracranial hemorrhage, unfortunately, the evidence was very low, but there was not even any trends in those observational studies. Some were saying that the platelets were helpful, and others were saying platelets were harmful. So it really, this is supposed to be an evidence-based task force, and so we essentially, since the evidence was so contradictory, we said we essentially could not make any recommendations for or against platelet transfusion among those patients on antiplatelet therapy with intracranial hemorrhage. So I think these platelet transfusion thresholds and guidelines can really be summarized by Wile E. Coyote when he's trying to hunt and eat road runner. So if we look at the prophylaxis for patients with the hematology oncology patients, he's on relatively stable ground with those recommendations. However, for almost all the other recommendations, the ground is a little less certain. So all of those recommendations were based off a systematic review that was also just recently published in the journal Transfusion. And when we first set out for these guidelines, we looked at not just those categories I just mentioned, but we also looked at patients with thrombotic thrombocytopenia purpura, heparin-induced thrombocytopenia, and immune thrombotic thrombocytopenic purpura. And there were little data available on the risks and benefits associated in platelet transfusions in these disorders. For TTP patients, there were only a few observational studies of about 400 patients. And the evidence-based transfusion guidelines in platelet consumptive disorders are essentially either non-existent or consensus statements based off insufficient data. Thus, after participating on this systematic review, I came home and started thinking, what can we be doing and thinking about more platelet transfusions in TTP patients? Because we've always been thought that platelet transfusions in these possible disorders could be harmful. And the reason for that thought of the hypothesis that platelet transfusions in TTP patients is that it's hypothesized to provoke a fatal thrombotic event, particularly in arterial events such as in patients with TTP and heparin-induced thrombocytopenia. As you're all very well aware, the platelet plays a very critical role of hemostasis at the endothelial and also plays a role in inflammation and mediating pathogenesis. In TTP patients, the principal histologic abnormality is proposed to be a platelet microvascular thrombus. And among those individuals undergoing autopsy who died from TTP, there are large components of the thrombus is composed of the platelet. Among those individuals with heparin-induced thrombocytopenia, it's been hypothesized that a formation of a heparin-dependent antiplatelet factor immune complex leads to immunologic platelet activation, thrombogeneration, and then increased thrombotic risk. Among those individuals with ITP, there's an unclear role of platelet transfusions in the management of ITP patients. And it's thought that the platelets have shortened survival in these individuals, suggesting that they may not be of clinical benefit of this condition, but not necessarily harmful. So a fellow and I started using the nationwide inpatient sample database, which is derived from the HHS, our Department of Health and Human Services, and contains 8 million unweighted records for inpatient visits every single year. And this is a 20% stratified sample of U.S. hospitals that generate nationwide weighted estimates. Over 1,100 hospitals across the United States and 47 states participate in this database, and it's projected that this database covers 90 to 97% of the U.S. population. Thus, we merged 5 years of data from 2007 to 2011 and identified on discharge codes those patients with TTP, HIT, and ITP. And then we explored the association of platelet transfusion with bleeding, venous and arterial thrombotic events, acute myocardial infarction, stroke, and in-hospital mortality. And we used univariate and stepwise multivariate logistic regression to calculate the odds ratios. So among those individuals, previously the best data was about 400 patients with TTP that had been evaluated in terms of platelet transfusion. And in this database, for those 5 years that we analyzed, we found 10,000 discharge diagnoses with TTP. Most of these individuals were adult, about 50% were Caucasians. But as you know, although we've always hypothesized that platelet transfusions may be associated with thrombotic risk in TTP patients, 10% of all admissions in the United States during these 5 years, patients had a platelet transfusion. Among those individuals with heparin-induced thrombocytopenia, again, the majority are adults, and 7.1% of all inpatient admissions were received a platelet transfusion. And among the 80,000 patients with ITP, although the efficacy has been questioned about platelet transfusion, 26% of all inpatient admissions in the United States, those patients receive a platelet transfusion. Now, what are the complication rates among these patients? Well, in terms of the bleeding, 13.7% of TTP patients during their admission had some sort of bleeding event. The majority were genitourinary bleeding. 5.7% of patients with heparin-induced thrombocytopenia had bleeding, and 11.5% of patients with ITP had bleeding. Among those with thrombotic events, there were 4.1% of all diagnoses in the United States with hospital admissions that had a thrombotic event. 3.8% were venous and 0.3% were arterial thrombotic events. 20% of patients with heparin-induced thrombocytopenia had a thrombotic event, and 0.9% of patients with ITP had a thrombotic event. Now, what are the odds of a thrombotic event in those patients with a platelet transfusion? Now, in terms of those individuals who had some sort of bleeding, the odds of bleeding associated with platelet transfusion was 2.3-fold higher. Now, this is just an association. The big limitation of this database is we do not know whether the platelet transfusion came first or the bleeding event came first. So you would logically assume among these individual events that among those individuals who were bleeding, then there is a 2.3-fold higher odds of platelet transfusion. You see a higher odds of platelet transfusion among those patients with heparin-induced thrombocytopenia and also with ITP. Now, what we find most interesting is among those individuals who had a platelet transfusion, your odds of an arterial thrombotic event was almost 6-fold higher in TTP patients among those with a platelet transfusion compared to those individuals without a platelet transfusion. Your risk of an acute myocardial infarction was also 2-fold higher if you'd received a platelet transfusion compared to those without a platelet transfusion. You also see a similar risk increase among those individuals who received platelet transfusion among those with heparin-induced thrombocytopenia. However, you do not see any increased risk among those patients with ITP with a thrombotic event or a myocardial infarction. Now, these were adjusted for age and gender and then also severity of the disease. Now, the big limitation of those individuals with the big limitation among those individuals receiving a platelet transfusion on a thrombotic event is we don't quite know, which came first. However, we also looked at what is the percent of death among those patients with TTP. And among TTP diagnoses and inpatient hospitalizations, 9% of all patients diagnosed with TTP in the United States died during that hospital event. Now, if we look at the risk of platelet transfusions and risk of mortality, and hopefully that platelet transfusion occurred prior to death, I think that would be a relatively simple assumption to make. Among those individuals who received a platelet transfusion, your risk of mortality increased 2-fold, even after adjusting for age, gender, and severity of disease. You see the same increased risk among patients with heparin-induced thrombocytopenia. There's about 3-fold increased risk of reported bleeding, 5.5-fold increased risk with platelet transfusion, and even after adjustment for everything, there's about a 5-fold risk, higher mortality among those individuals receiving platelet transfusion. So what are the strengths of these data? Really, it's providing the first nationwide estimates of platelet transfusions in patients with platelet consumptive disorders. It also uses the largest publicly available comprehensive all-payer inpatient database in the United States, and the nationwide inpatient survey has been extensively validated against national hospital discharge surveys. So there are a number of strengths. However, there are also a number of limitations. One is the temporality of the events has not been reported, as we recently discussed. There's no information on platelet thresholds for transfusion or disease severity and the effect of the outcomes, and the accuracy is limited by the precision of discharge coding. So in summary, in terms of this area, platelet transfusions are frequently administered in patients with platelet consumptive disorders, including TTP patients, heparin-induced thrombocytopenia, and those patients with ITP. Platelet transfusions are likely administered to sicker patients and those with clinical bleeding. Platelet transfusions is associated with higher odds of arterial thrombosis and higher odds of mortality among those patients hospitalized with a diagnosis of TTP and HIT. Thus, we recommend that platelets should be considered to be relatively contraindicated and used only for severe or life-threatening bleeding refractory to other therapies in patients with TTP and HIT. So what are other methods to prevent other adverse events of platelet transfusion, such as allergic transfusion reactions? Well, and as we sort of discussed at the beginning with AABB's platelet transfusion guidelines, is allergic transfusion reactions are one of the most common events associated with platelet transfusions. About 2% of all platelet transfusions are associated with an allergic transfusion reaction, and it's a spectrum of a hypersensitivity reaction to transfusion blood that leads to essentially itching and hives, but there can be severe reactions such as anaphylaxis. And it clearly appears that it's both donor and recipient components that play a role in allergic transfusion reactions. For a long time, it's been thought that diphenhydramine, which is an agonist of the histamine H1 receptor, and it leads to rapid and effective reversal of large quantities of histamine release, and has been previously shown to reduce the intensity of allergic transfusion reactions, may reduce allergic transfusion reactions if we provide it as a pre-medication. Every day we have, at Johns Hopkins, we have platelet transfusion coordinators, and after the first allergic transfusion reaction, they always say, okay, what type of pre-medications should we provide? And I think that's sort of a standard therapy, and it's based off 3 studies in the 1950s. However, there have been a few changes in our discipline since the 1950s. These studies were people injecting diphenhydramine directly into whole blood bottles. There was no component therapy. There was no leukoreduction. And finally, these were very poorly run studies. There were no randomized trials. But these 3 studies, and is a nice hypothesis that diphenhydramine should reduce allergic transfusion reactions. So we did a literature review looking at diphenhydramine pre-medication to prevent allergic transfusion reactions. And there are 2 randomized trials that have been published, which is the gold standard of data. One by Wang looking at platelets, and is a relatively small study of 51 patients and 98 transfusions. However, they found no difference among the allergic transfusion reaction rate among those who received diphenhydramine pre-medication and those who did not. There's a second randomized trial by Kennedy looking at platelets and red blood cells among 300 patients and 300 transfusions. And once again, they found no difference that diphenhydramine reduces allergic transfusion reactions. There was one prospective study by Patterson that what they did is they changed their pre-medication policy. So instead of 60% of patients receiving pre-medication, they limited their pre-medication, and that rate dropped down to below 30%. However, prospectively, what they found is that there was absolutely no change in their rate of allergic transfusion reaction, even while they limited the number of pre-medications with diphenhydramine. There have also been a couple retrospective studies by Sanders. This was among children at St. Jude's Hospital of 385 kids and 7,900 transfusions, and there was no benefit of diphenhydramine to prevent allergic transfusion reactions. And finally, there's a Stevens study, which is a retrospective study of 31,000 patients and over 300 transfusions, and once again, they found no difference. There's actually not one study, except for those ones in the 1950s that I'm aware of, that shows any benefit of diphenhydramine to prevent allergic transfusion reactions. But it is an absolutely lovely hypothesis. The only problem is that Thomas Huxley, who was one of Darwin's bulldogs for his advocacy of evolution in the 1800s and was one of the greatest English comparative anatomists, said, "The greatest tragedy of science is the slaying of a beautiful hypothesis by an ugly fact." And I think that's really where we're at with these data. However, there are a few side effects of diphenhydramine. It's not just that we're providing something that doesn't work. It's a potent anticholinergic that leads to drowsiness, dry mouth, and urinary retention. It may impair driving performance, which is an issue for our outpatients. It may acutely interfere with memory function, attention, and psychomotor performance for our inpatients in the ICU who already have some of these issues. And there is a financial cost. St. Jude's Children's Hospital estimated pre-medications cost more than $40,000 annually, plus pharmacists and nursing time just to provide these. So, Albert Einstein said, insanity is doing the same thing over and over again and expecting different results. Thus, at Johns Hopkins, we've really tried to discourage pre-medication with diphenhydramine to prevent allergic transfusion reactions. We believe we have tried to decouple those order sets that provide your platelet transfusion, and then right below it, it says, what type of pre-medications do you want? It's encouraging our clinicians who don't know any better to think, oh, that pre-medication works. It's right below the platelet transfusion order. I'll check that box too. So what methods can prevent allergic transfusion reactions? And I think this is really where our job comes into play. And the laboratory can play a critical role to prevent these allergic transfusion reactions. We evaluate whether removing plasma from apheresis platelets or red cells by concentrating or washing transfusion products can decrease allergic transfusion reactions. As I said, up front, we think there clearly is a component in the plasma that's causing these allergic transfusion reactions. So we did a retrospective cohort study of 179 individuals who received unmanipulated and then subsequently concentrated or washed apheresis platelets. And all these transfusion reactions were diagnosed in real time based off definitions from either the biovigilance criteria or before that by using the technical manual criteria. And we used Poisson regression with generalized estimating equation to estimate the incident rate ratio and 95% confidence interval of allergic transfusion reactions. So to be in this study, you had to have already, it's a retrospective study. So you already had to have had multiple allergic transfusion reactions and then already been previously placed on either a concentrated protocol or a wash protocol. So as our concentrated protocol, we use the COBE and we reduce the plasma in that of apheresis platelet down to just 100 mils. And the washing, we wash with either 1 or 2 liters of normal saline. So among the allergic transfusion reactions to apheresis platelets, among those 179 individuals, again, these were high reactors, so the incidence was 5.5%. Our general incident rate at Johns Hopkins is about 1.7%, but these are candidates who we knew were continually reacting. So we had 179 patients with an incidence of 5.5% over 5,000 transfusions. However, if they had single or multiple allergic transfusion reactions, they were placed on a concentrated apheresis platelet protocol for 135 individuals, and their reaction rate went down from 5.5% to 1.7%, which is fairly decent. For 91 of those 135 individuals, their incident rate was actually 0.7%. They stayed pretty low, and they responded very well to having concentrated platelets. However, there were a number of individuals who continued to have multiple allergic transfusion reactions. If they were on a concentrated platelet protocol and continued to have allergic transfusion reactions, we placed these individuals on washed apheresis platelets, and then our incidence went down to 0.4%. Occasionally, we have a few people who have severe life-threatening allergic transfusion reactions. Thus, if you have an anaphylactic reaction, we usually don't start messing around with concentrated protocols. We put you immediately on washed apheresis platelets. And among those individuals, those 44 individuals in this retrospective study, if we put you on a washed apheresis platelet protocol, your incident rate ratio went down from 5.5% down to 0.7%. Thus, concentrating apheresis platelets reduces your allergic transfusion reaction by about 73%. Washing apheresis platelets reduces allergic transfusion reactions by 95%. And washing red cells reduces allergic transfusion reactions by almost 90%. Thus, there's some substantial benefits for concentrating and washing our apheresis platelets to reduce our allergic transfusion reactions. But you always think, are we losing some type of product when we're doing this? Are we, how's our increment for this? So we did a follow-up study looking at what is, how much product are we actually losing when we're concentrating or washing platelets. So among those individuals, among 5 mils of concentrated platelets, we see about a 20% reduction in the platelet count among those platelet units that have been concentrated, and we also see about a 20% reduction in the platelet count among those units that have been washed. So right off the top, we're losing about 20% of our product just by concentrating or washing apheresis platelet units. However, what's the impact in vivo? So looking at using our increment of platelet counts among those individuals who've been transfused, what we see is among those individuals who have unmanipulated or just standard apheresis platelets, you have an increment of about 6,000. If you really want to talk about it, we calculate our increment a little odd compared to almost everyone else. So it's about, this really should be about 1.8-fold higher compared to other ways you calculate increments. But as you see, you get a pretty decent increment at 0 to 2 hours, and then over time, over 24 hours, you decrease your increment, and this is just how you would logically expect it to be. However, among those individuals who received concentrated platelets, it's about 20% lower all the way down. And then among those individuals who have washed apheresis platelets, it's even lower. So these are only individuals who received both regular platelets and concentrated or washed platelets. So it's not comparing two different sets of individuals. This is among the same individuals. However, as I said, off the top, we're losing 20%. So if we adjust for that 20% loss, as you can see, the in vivo increment is really about the same between those receiving standard apheresis platelets and those receiving concentrated apheresis platelets until about 24 hours. However, among those receiving washed apheresis platelets, it appears the washing does seem to be damaging the platelets in some fashion. So we are decreasing our increment all the way down. And in this study, among those individuals who are receiving washed apheresis platelets, after they were put on washed platelet protocols, they were receiving significantly higher number of platelet transfusions after being put on that washed apheresis platelet protocol. So concentrating and washing platelets and red cells significantly reduces allergic transfusion reactions. They can be helpful for patients with severe or multiple reactions that cannot be otherwise prevented. And platelet and red cell manipulation should not be employed for all patients since they're costly. They reduce the shelf life and reduce platelet in vivo effectiveness. So what is the role for platelet AV solution platelets to reduce our allergic transfusion reactions? In platelet additive solution, there's been a long history of its use in Europe to increase plasma supplies for transfusion and also for fractionation. In 2010, platelet additive solution was approved by the FDA for use with Amicus. And a platelet additive solution may facilitate the use of ABO-incompatible platelets. It may also increase the storage duration or be manipulated as part of a pathogen reduction technology. And we hypothesize because you're reducing the amount of plasma you're giving the patient, it may reduce your allergic transfusion reactions. Thus, we performed a study using platelet absolution apheresis platelets, which platelet absolution platelets comprise a mixture of 35% plasma, so about 100 mils of plasma, and 65% Intersol, which is the FDA-approved product in the United States. On June 1, 2012, our institution began to receive platelet absolution apheresis platelets in addition to our standard or non-pass standard plasma suspended apheresis platelets. And we started a mixed inventory of both platelet absolution platelets and standard plasma suspended platelets, and we've continued a mixed inventory. We did a retrospective evaluation after 6 months to evaluate the rate of transfusion reactions, including allergic reactions, febrile reactions, and other reactions such as trolley, and also evaluate the increments. The exclusion criteria, we evaluated everyone except for a few exclusions. Patients receiving aliquots, thus if you didn't receive an entire product. Patients receiving manipulated products such as concentrated washed products were not included in this study. And patients requiring HLA matched platelets were not included in this study. So among those individuals included in this study, there were almost 4,000 non-apheresis platelet transfusions involving 604 patients and almost 1,200 pass apheresis platelet transfusions of 345 patients. Those 345 patients also, every single one in this study received non-pass apheresis platelets. So that 345, that 604 includes those 345 patients who received the pass apheresis platelets. So what is the instance of our allergic transfusion reactions? Well, among those receiving standard apheresis platelets, we are very happy to see at 1.85%, which is our normal reaction rate. So this appears to be relatively stable and legitimate data. And among those individuals receiving pass apheresis platelets, our instance of allergic transfusion reactions was 1.01%. Thus, there's a 46% reduction in allergic transfusion reactions among those individuals who received pass apheresis platelets. Among looking at febrile non-hemolytic transfusion reactions, our instance was 0.7% receiving standard plasma-suspended apheresis platelets. Among those individuals receiving pass apheresis platelets, the reaction rate was 0.6%. Thus, there is really no significant difference between individuals receiving pass apheresis platelets and a reduction in febrile non-hemolytic transfusion reactions. So we see a reduction in allergic transfusion reactions, but not febrile non-hemolytic transfusion reactions. Among those other reactions, of those almost 4,000 standard apheresis platelet transfusions, we saw 3 episodes of transfusion-associated circulatory overload, 2 transfusion reactions associated with hypotension, and 1 case of trolley, which is a rate of 0.03%. And it was a male donor. On subsequent evaluation with the Red Cross, there were no risk factors, but the donor did have neutrophil antibodies and multiple class 2 HLA antibodies. So it did appear to be a real case of trolley. Among those 1,200 pass apheresis platelet transfusions, there were no instance of taco, trolley, or hypotensive transfusion reactions. However, one caveat to this study is this study was not powered to assess differences in these other types of transfusion reactions. So although we didn't see any allergic, or we didn't see any trolley, taco, or hypotensive reactions, I'm not sure you can really make any conclusions because the study was not powered for those data. We also looked among those individuals who received pass apheresis platelets and standard plasma suspended platelets, looking at the corrected count increment. And to be included in this part of the study, it had to be the same individual who received pass standard platelets and pass apheresis platelets within a 7-day period. On the days of both transfusions, the patient had to have similar bleeding status in terms of WHO bleeding score, similar maximum temperature, whether they were febrile or afebrile, but similar both times, and similar post-transfusion labs at 1 to 4 hours and 12 to 24 hours. Among those 223 patients with paired standard platelets and pass platelets, what we found is that at 1 to 4 hours, the increment among those standard apheresis platelets was almost 5,000. Among those with pass apheresis platelets, it was about 3,700, which was significantly lower at that 1 to 4 hours. However, at 12 to 24 hours, the increment was about 2,100 for the standard apheresis platelets and was a little over 1,700 for pass apheresis platelets, which was not significantly different. Thus, there appears to be a lower increment at 1 to 4 hours, but it's trending lower, but not significantly different at 12 to 24 hours. So simultaneously, while we were conducting our study of pass apheresis platelets, there was an individual multi-center study of pass apheresis platelets. And individuals were randomly assigned to receive either plasma or pass platelets based on available inventory. And in this study, there were over 1,400 patients who received 4,000 pass apheresis platelets and 2,000 patients who received almost 10,000 standard plasma platelets. And there's an active surveillance of adverse reactions, and these definite allergic reactions and other reactions were defined using the hemovigilance definitions. Overall, in this study, they found that adverse events were 0.55% among those individuals receiving pass apheresis platelets and 1.4% among those receiving standard platelets. Thus, overall, there's a reduction in reactions among those receiving pass apheresis platelets. There was a 65% reduction in allergic transfusion reactions among those receiving pass apheresis platelets. They also found a significantly lower rate of febrile non-hemolytic transfusion reactions among those individuals receiving pass apheresis platelets, which is different from what we found, but it was a larger study. Now, they did not find any cases of trolley in either of the study arm. So there appears to be some benefit of pass apheresis platelets to reduce allergic transfusion reactions. So bottom line, we're coming from the hospital. What is the cost effectiveness of platelet absolution platelets to reduce allergic transfusion reactions? My administrator is sitting at me saying, do I really want to possibly pay any extra for pass apheresis platelets? Am I saving any money? That seems to be a lot of what the administrators are driving at these days. Thus, we performed a cost-effectiveness study of platelet absolution to prevent allergic transfusion reactions. And allergic transfusion reactions lead to increased health expenditures on multiple levels. There's prolonged time required by floor physicians and nurses. There are additional resources to address your allergic transfusion reactions in the blood bank. Mild allergic transfusion reactions typically require some antihistamine treatment, and severe allergic transfusion reactions can lead to costly hospitalizations for outpatients or prolonged hospital stays for inpatients. There's also some time and cost for concentrated washing platelets. Now, our medical technologists, whenever we're sitting in our rounds in the morning, I say, I think maybe it's time to start concentrated washing this platelet. You can just hear this low-level groan of not another patient we need to be washing for. So there's increased labor costs, and as we've seen, there's also a decreased increment. So we constructed a Markov-based decision tree model to follow a cohort of hypothetical patients as they were transfused and assess the associated costs and allergic transfusion reaction rate. And we based this off a hospital-based perspective. So our algorithm, our Markov decision tree was very similar to how I described our retrospective study of putting people either on concentrated or washed apheresis platelet protocols. So if you do not have any allergic transfusion reactions, you usually receive standard apheresis platelets, and you keep going through and circling through that way. However, if you have a mild allergic transfusion reaction, most people just keep going and stay on a standard plasma product. However, among those individuals who have multiple allergic transfusion reactions, we then think about modifying their protocol in some way. And as I shown, historically, we have put these individuals on a concentrated protocol. If they don't have any allergic transfusion reactions at that point, they stay on a concentrated apheresis platelet protocol. among those individuals with severe allergic transfusion reactions, or even if they've received concentrated platelets and they continue to have allergic transfusion reactions, they get placed on a modified protocol, which is usually a washed apheresis platelet protocol. At that point, usually we've reduced our number of allergic transfusion reactions. So that is our baseline strategy. So we said, what if instead of using a concentrated apheresis platelets, once you've had multiple allergic transfusion reactions, instead of putting you on a concentrated apheresis platelet protocol, what if we put you on pass apheresis platelets to reduce allergic transfusion reactions? And then if you continue to have reactions, we'll put you on washed apheresis platelets. So you start out with standard plasma platelets, you go to pass, and then wash. Then we ask the question, what if we place these people, instead of keeping a mixed inventory, if we just put these individuals, everyone, on pass apheresis platelets? And then if they continue to have allergic transfusion reactions, they'd go to concentrate or wash. And then our final question was, what if we can convince our clinicians that pre-medications don't work, we're giving them possibly a superior product to reduce allergic transfusion reactions, and we can convince them not to use pre-medications anymore, and we give them pass apheresis platelets. If they continue to have reactions, you go on to concentrated products and then washed apheresis platelets. And this analysis incorporated an assumption of a reduced allergic transfusion reaction rate of 56% for pass apheresis platelets. This is slightly higher than the data I showed at Hopkins, and the reason for that is this is what they found in Europe, and we did this study before the Hopkins data. So I was actually quite nervous when we were doing the Hopkins analysis that we wouldn't find any difference, and then this study had already been published. But fortunately, it's all around that 50% rate. So we didn't have to retract anything that we'd previously stated. So if we put people on pass apheresis platelet after multiple allergic transfusion reactions, even if the Red Cross or the blood supplier increases the cost up to $50, it was always cost savings. So we had spoken to our Red Cross as our supplier. We'd spoken to them, what is the possible range that pass apheresis platelets could increase, and we thought it would never go higher than $50. So we ranged it from $0 to $50. So even at that maximum cost, if we put people after multiple allergic transfusion reactions, instead of putting them on a concentrated protocol, we put them on a pass apheresis platelet protocol. It is cost savings. However, we also did a one-way sensitivity analysis varying all costs of pass apheresis platelet storage while holding all other input variables constant at their base case scenario. So if we put people on a pass apheresis platelet protocol with pre-transfusion medications, as long as we don't have an upcharge of greater than $9.13, it is cost effective to have everyone start out on pass apheresis platelets in terms of reducing allergic transfusion reactions. Among those individuals, if we can convince our clinicians that we can scrap all the diphenhydramine pre-medications, even if pass apheresis platelets increased by almost $12, it's cost effective. For us, I believe Ralph Vasella told me recently that the Red Cross is charging about $10 more. So it's essentially cost neutral putting these patients on pass apheresis platelets at our institution. So for possible uses for pass apheresis platelets are for general platelet requirements, including oncology and surgical patients, for patients who are sensitive to allergic transfusion reactions that they've had previous minor allergic transfusion reactions, and as plasma-reduced products in the setting of ABO plasma-incompatible transfusions. However, we prefer our standard plasma-suspended platelets for patients who are also coagulopathic. It really doesn't make a lot of sense to give people a pass apheresis platelet and then a bag of plasma right next to it. So at that point, for those coagulopathic patients, we still, we keep a mixed inventory, and we keep with standard platelets there. So in summary, there's no evidence that pre-medication with diphenhydramine is effective in preventing allergic transfusion reactions. Platelet reduction is associated with lower incidence of allergic transfusion reactions, and platelet AV solution platelets are also reduce allergic transfusion reactions. And past apheresis platelets may be cost-effective for hospital transfusion services. So in conclusion, prophylactic platelet transfusion should be avoided in stable hematology-oncology patients with a platelet count greater than 10,000 cells per microliter from our AABB guidelines. Platelets should be considered to be relatively contraindicated in patients with TTP and heparin-induced thrombocytopenia. Platelet AV solution platelets may be useful for individuals sensitive to allergic transfusion reactions. Washed platelets should continue to be employed for individuals with repeated reactions and for the prevention of severe reactions. And further research on platelet transfusion adverse events are urgently needed to provide new techniques to prevent them. Finally, this work is I'm presenting on behalf of a large group of investigators at Johns Hopkins, at Brigham and Women's Hospital, and Case Western Reserve University. So thank you very much. I appreciate your attention. I believe we have a couple minutes for questions if there are any. I guess it's clear as mud, so thank you very much.